All right, welcome back to the Full Arch Podcast. I am here with probably one of my most famous guests that we've had so far, and certainly one that has earned my very deep respect. The one and only Bernardo Nunes de Sousa. He is here with us today, all the way from Portugal, and super happy to have him on. I can't wait for him to just kind of take things away. How are you doing?
I'm great, man. How are you?
I'm very good. I've actually gotten a ton of really great feedback on the last couple of episodes that I did with Dr. Soren Poppy, where we talked about your course and our experiences and the things that we've learned and the things we've gotten ourselves into since your course. And so to be able to have everything straight from the horse's mouth, as they say, is really, really exciting. And I feel like it's a big highlight for the show. So I'm just super grateful that you're willing to come on.
Yeah. I saw that episode actually in Soren's Instagram story. Oh. He put the story, and I was like, Bernardo, it's me.
That's me.
What is this about? Then I listened to that, and I was like, well, I didn't ask for it, but such a nice review. So thank you, man. It was very kind from both of you to do that.
Yes, well, I mean, it's certainly not just out of kindness. It's just it's a message we wanted to send to other people that are in similar places and want to step up their game. And your courses certainly have done that for us. And so I kind of want to establish a little bit more background because I don't think anyone can do it better than you can. About who you are, where you come from. You're obviously a very young guy that a lot of people are taking very seriously and using as as an authority in the full arch world. But I want, if you wouldn't mind, just kind of shedding some light on where you come from, your whole dental journey, how you got to where you are. You can even go back to childhood if you need to.
All right, so I will try to keep this part short, but it all started actually. When I was 6 years old, my parents have a videotape, a beta video. You know what is a beta tape?
Like a Betamax or something?
Like a VHS, but a little smaller.
Yes.
And I had this video, and someone asked me, it was my birthday party, what I wanted to do when I grew up. And I said to the guy that I wanted to be a dentist.
No way.
And I think that it's a true story, and I think that happened because I really enjoyed going to the dentist because that dentist was a friend of the family.
Oh, cool.
And I really enjoyed the guy. So, through all my life, this somehow was in my mind. And so finishing high school, we have to decide in Portugal, we don't have college. So we go straight from a high school to the university. And let's say in those tests that they do, to see your personality, what kind of fits best on you, I scored very high, like 98% in only two things. It was military or medicine. And I was very interesting on both of them, actually, because I really liked the rules, I like protocols. I like standardized things, not only things, but also to standardize thoughts about things. And I had to make a decision, and I decided to go to dentistry because that's what I wanted to do since I was 5. That seems. And so during university, I only cared about oral surgery. I found that most of the other subjects. I was not seeing myself doing that when I actually became a dentist, but I saw myself doing the surgery, and also in the clinic of the university, I found that the oral surgery was somehow the cleanest topic of all, because you do your stuff, you suture, and it's done. You can do everything in one single. You don't have to do restoration after restoration, then scaling, root planning, multiple sections of endodontist. It was very.
No, you're singing to the choir here. So.
It was. It was such a clean thing that we could do, and it was not that long. It was not boring. And it was also done with the hands, And I think that if anyone wants to become a dentist, and nowadays I know there is a lot of people going into dentistry not because of passion, but because it's very profitable. But to go into this field, we need to be good at hands, Since I was 13 years old, I was playing guitar. I was doing.
Yeah.
I was actually a guitar professor in the university to help pay for the rent.
That's awesome.
So, and oral surgery gives you this. You do something with your hand. You take out the wisdom, the impacted one. You have to be gentle, but strong at the same time. And so after university, I saw the interview of Paulo Malo, at national TV. I still have the print screen of that. I think I showed you.
Yes, you did.
And Paulo was saying in the national television that he was doing these impossible cases, full arch impossible cases, under 1 hour and always with immediate loading. So that was very interesting to me, because when I was a student, we are talking about from 2007, 2011, 12, the standard was, for example, in the upper arch was double sinus, wait 6 months, wait 9 months, place the implants, wait 4 more months or 6 more months. And maybe after 1 year and something, the patient would have fixed teeth. And, watching Paulo's interview made me search for more interviews about him. So I digged a lot. It was the beginning of the YouTube. Things were start to become available online. And then I started to read the articles to see if the literature, was somehow supporting his claims. And I searched all these initial studies about the Alan Ford, but also the studies that were comparing tilted with straighted implants, the studies that compare that, all these studies I showed you in the course, comparing the number of implants. Very interesting that, for example, Brunmark himself, he started in 1985 comparing the number of implants. And he did the study for 10 years. Can you imagine to think about this in 1985, following the patients for 10 years, and then publishing in 95 and saying that the present tendency of some doctors to use as many implants as possible should be seriously questioned. So when I started finding these studies, I decided, well, I have to work with a guy. I want to work to learn from the source, to learn from Malo, and because these things just make total sense to me, and we see this in architecture, you see this in all fields of engineering, that 4 pillars are the essential, how can I say, foundations for any structure. It's rare to see 6-side stuff. I don't know if I'm explaining myself totally right, but a car has 4 wheels, a small house has 4 main pillars, and so that just made so much sense that I tried to work with him. But maybe in the States happens exactly as in Portugal. If you want to go to a very high-end practice, maybe you need to know someone that knows someone that eventually will pull the strings and will put you there.
Nepotism is universal.
It is, right?
Yeah.
So yeah, it happened that I was the first dentist in my family. So I didn't know anyone to pull these strings for me. So I had to go somewhere around this. And I did this very interesting journey in the Netherlands. So I stayed there for almost 1 year, doing a postgraduate program in maxillofacial surgery. But it was not related to implant dentistry. It was oral surgery and maxillofacial surgery, the serious part. And so I didn't have the chance to rehabilitate these people. It was just not our focus. So after this, I went to Cuba. I did the basic oral surgery program and the advanced maxillofacial program. I was living with a Cuban guy in his house, which happened to be my professor as well.
That's great.
It was such a nice experience. They treat me very well. And in Cuba was one of the biggest lessons I learned in my life, which is we don't need that much stuff to do great things. They live in difficult conditions, at least when I was there. It was pretty rudimentary, and I was doing this program at the University of Havana. And so you can imagine we had like 1 forceps, 1 elevator, 1 end piece, and 1 drill, and that was it. So working with less tools automatically forces you to be more skillful with your hands. And this lesson was one of the foundations of the Full Arch Club, which is we, as the time goes, we rely more on products, on this specific tool, on that specific tool, instead of doing the best and the most of what we already have, which many times is enough if we do it right. And so this story in Cuba taught me a lot about working with good oral surgery principles. And I've told you this before several times. For sure you remember the 3 basic principles that we always apply in the Full Arch Club and also in the live surgery boot camp in Brazil. Access, visibility, and illumination. And is really the 3 things that are most important in any surgery, not only oral surgery. So,
and can you I do want to stop you just for a second. So let's elaborate a little bit on access, visibility, and illumination. Can you?
So access,
please,
that's a
go
great
ahead.
question. Yeah. So the access has to do with your ergonomics, where your position has an operator. And you remember for sure because you were one of the best students we had in both courses actually.
Thank you.
I'm not saying this for the camera, and it's you won. Alpha Team won the boot camp challenge.
I don't think I'm not sure if I mentioned that in the last episode, but now you've said it, so I can talk.
No,
about
you didn't, but you should. We'll talk about that later.
Of course.
So the access has to do with your position as an operator. You need to put yourself in that specific position for the upper and then another position for the lower.
Yes.
And your position as operator actually doesn't change. What changes is the back of the patient. It's the only variable that changes from upper to lower. That was the access. The visibility has to do with the flaps. So open a flap in such a way that you see everything that you are doing, that you see your working area. And the illumination has to do with not relying on the light of the dental chair, which is awful most of the times. It's not for this, it's not for bloody fields, and having an extra light with you. So when you put all of these things together, your surgery becomes like 70% easier.
Yes.
Because you see what you are doing.
Yep.
You have access to your working area. And so
thank you.
I think we covered these, right? Yeah.
Yes, absolutely. Thank you.
So we were talking about the journey.
Yes, of course.
After Cuba and after I told you about the Netherlands, right?
Yes, we did Netherlands and then Havana is where we're at. Yep.
So the Netherlands, Havana, and so after that, in Cuba, we also the implant part of the program was very small, because implant dentistry is expensive, and the implants themselves are expensive. So you can imagine that in Cuba you don't get to do a lot of this in Cuban patients unless it's an international course, which I was not doing that. I was there for surgery itself. Sure. So I still wanted to learn those techniques that I saw on that YouTube video and that I researched about the Alon 4 and the Alon X by Paulo Malo. So I did a 2 years master's degree. I think I was one of the few students who actually completed it, because many of them quit, during the program. And in that program, in my mind, what we were being taught, it was a bit outdated. And we were still doing, for instance, 4 implants for an overdenture, which is something that I never did in my professional life. I don't think I think we have a better strategy in terms of rehabilitation when we use 4 implants. And the overdenture is not one of them. So, and we were doing this in this program, and we were still doing double sinus lift, putting patients on dentures. So that program was nice in the sense that the fear of placing implants went away, but I still wasn't quite happy because that was not the end result that I wanted. I was all about immediate loading, trying to get the cases solved, in the first day, like in 1 hour or something. And And at some point I was like, well, I don't know if I will ever get the training or the knowledge that I want, because I mean nobody's teaching this.
Right.
And then suddenly magic happens in life sometimes. So during all this time, I was trying to send my resume to Malo Clinic to see if they one day they would call. And that day came, I remember quite well. One night I went out with my friends and I came home a bit tipsy, and I saw on Facebook, true story, man. I saw on Facebook that Malo Clinic was recruiting for Paris, for a clinic that was about to open in the future.
Yeah.
And at that time, with the right amount of alcohol, I said, well, it doesn't seem that bad to go to Paris for a while.
Yeah.
So, I applied to that. 1 week later, they called me, and I was supposed to stay in Lisbon, at the headquarters, working at Malo Clinic headquarters, and I will have to do my training there before going to Paris.
Okay.
That didn't seem that bad. So, my first day there, it was a quad zygo with Malo. So, you can imagine how fascinating that was for a very young guy,
Yeah, I want to shed some more light on this. So at this time I think you said this is early 20s, 22, 23 when you're doing this, or maybe a little.
So I finish university. I was 22. So I was maybe 24.
Okay. Yeah. 24 on the quad zygo. Yeah. That has definitely never happened in the United States. No chance.
Well, I was helping him. I was the second surgeon, not the first.
Okay.
But still.
Fair. Still. That's crazy.
Opening for a quad, it's a different, slight different approach. And it was for sure fascinating for me. And the most valuable lesson during these 2 years and something at working with Paulo, because I didn't want to work for him, I wanted to work with him. And that's the biggest difference whenever you go to a good company. If you get to work with the CEO or with a very proficient guy, you can grow a lot.
Yeah.
But if you are just there, doing small stuff, and you also don't show your intention to learn with the guys, that's not that great. And I told this to Paulo, that I wanted to work with him.
Yeah.
And so you can imagine, after these 2 years, you see thousands of cases. For you to understand, Tyler, the Malo Clinic in Lisbon was at the time the biggest dental clinic in the world. It was 18 stories building.
Yeah.
We were doing like 10, 15 full arches per day, every day. So the whole 9th floor was our floor, was the surgery floor. So with this amount of cases per day, and with the follow-ups that you get to see there, since 1999, since the year 2000, I mean, we can read as many articles as you want, but the numbers don't lie.
Yeah.
Yeah. You can write, you can publish, you can write books, but if you don't have the numbers, or if you compare, an article that someone, studied 50 cases to the experience of someone that has 30,000 cases, I mean, the difference is in the numbers. So that for me, it was so important to see those numbers and to see the follow-ups. And at the end of those 2 years, I was thinking to myself, well, if I had the smallest question about the graftless techniques, I don't have it today, because I have seen, enough to clarify any question I might have. And the experience in Cuba, the experience with Malo Clinic, I gained a lot of experience. After this, I went to the biggest DSO in Portugal. We have also DSOs in Portugal.
That's good to know.
Only in the States. And I was the clinical director of one of the units, of one of the offices. And during the first 2 years, I worked there about 5 years, or almost 6 years, I believe. During the first 2 years, my job was to redo 150 cases that were, in litigious with the company. Things done previously that went
great.
wrong, that went sideways.
Great.
And so I spent my first 2 years redoing cases.
Wow.
And that gave me also a lot of experience in this part, which is what do you do when they fail? When things go south, when you have, I don't know, the Allen 4 has failed one time, second time, what do you do now? And solving complications during these 2 years also, it was quite helpful, because it's very easy to place them, but it's not that easy to redo them.
No.
So all these things together, I started to cook the idea. Well, when I was younger, I didn't have the course that I wanted. So maybe I should create one. And that was the idea behind the Full Arch Club, to try to put all this knowledge acquired over the years accessible to doctors that want to follow this path, without guides, without grafts, because the truth is that the implants placed in grafted sites have lower success rates compared to implants in native bone. So no grafts, no grafts, no guides, and always with immediate loading. This was always our motto since the beginning, still is today, and I think it will forever be like that.
Absolutely. Yeah. I mean, your story to me is so incredible, because you have had a lot of very unique experiences that give you an authority to say the things that you say. Because I think most of the times when you talk to someone who even does a lot of full arch, they're drawing from, their own experience, and maybe they're doing, 20, 30 arches a month, and that's fantastic. That's incredible. That's a very well knowledgeable person.
That's a very good number.
Oh, it's a huge number. I only know a handful. But having worked when I was in Portugal and I saw the Malo clinic, I didn't even know where it was. I was just walking down the street and I was like, wait a minute, is that the Malo clinic? And I thought, it looked like a small hospital. It blew my mind.
Yep.
And you guys were doing 10 to 15 arches per day. You're seeing all of these cases, and you spent time being the designated revisionist for DSO. So it's not, truthfully, it's really not that hard just to put some implants in bone and convert it and say, hey, look, I did an all-in-4. But when you're having to inherit one that you've seen now go south, and then you're having to redo that, you just have such a incredible breadth of experience with successful cases and not successful cases, with all kinds of different methodologies. And I'm so happy that you took all of that and made it something that's digestible for other audiences, people in the U.S. who would never really get that kind of exposure, because those sorts of things just don't exist.
Yeah, I said this one time in an interview before to a colleague of us, and I will tell this to you, which I think it's quite fundamental in our journey, which is this: learning from self-experiences is one of the most valuable things we must do. Not that we should, but we must do them. But learning from the experience of others is the ultimate superpower, because it means that you don't have to go through that yourself, and seriously, and I feel that this is something that we kind of miss in our generation. It's like we have to see it to believe it. Well, I can believe the follow-ups of others if I have a minimum of confidence in their word, and if they show me those cases and those follow-ups. And I'm certainly, when I was younger, I was not going to argue, let's say, with Paulo Malo, because this guy has done this 30,000 times,
Right.
So I would not even have the audacity to show him an article. Hey, look, but here says the opposite. I mean, it doesn't even make sense to me to approach someone, again, it's on the numbers. Those who have the numbers have the reason, and that was all about it.
Yeah.
But let me tell you something interesting.
Okay.
So the idea to create the group was just the night before a lecture I was going to give in, I think it was in Barcelona or in Madrid. It was in Spain.
Okay.
And the night before, I was just finishing my slides, reviewing everything. And I thought to myself, well, how nice would it be if the people from the audience of tomorrow could join in a group just after the lecture, if they have any doubts, any questions, if they want to follow up with these principles. So that was actually the trigger to create the group, the Facebook group.
Wow. So that was the original Full Arch Club. It was just a club of people that you had done a lecture for.
Exactly. And then I had to create a name for it, and Full Arch Group didn't sound...
It's not a good acronym.
Right, didn't sound Bernardo stuff, No. I wanted something more, how can I say, like a gang, like a clan, like there are many groups about Full Arch in the world that do Sinus, this and that, but at the club we are doing, graftless, immediate, no guides, and Full Arch Club seemed nice. I registered the name, the intellectual property, and that was it.
Beautiful.
And now the rest is what you know.
Yeah. So I mean, I'm surprised, with your proclivity for militarism, it wasn't like Full Arch Militia or something like that. I feel like you kind of missed you missed an opportunity. It would definitely match the culture in the boot camp.
That would be a nice name as well.
Yeah.
Full Arch Militia.
You can do something with it. Well, cool. So I've been taking notes as you've been talking. So there's just a few things that I think some people would have heard as you were talking and wanted to extrapolate a little more from it. So you did mention that you don't do 4-implant overdentures. So is that to say you just do 2-implant, 3-implant, or what's kind of your mentality with overdentures? It's a very common thing over
here. So I can speak about overdentures quite vastly, as I did. It was the subject of one of my master theses. I did 2 master theses, so one of them was exactly about overdentures.
Okay.
And for overdentures in the lower arch, you can use what most people use: 2 implants, 2 locators, and that's it. And that's perhaps the best, cheapest alternative to the lower removable denture. And because it stays in place, more or less, people can eat 70%, 80%, of better. So that's a quite cheap alternative to the removable denture, and that's how we should look at that. But for the upper one, the problem of the upper one is, for the upper one, you cannot do it on 2. You should do it on 4. And to use 4 implants and then placing 4 locator abutments, why don't you just put 4 MUAs and immediately load it? Yeah. It doesn't make sense, From a financial view, doesn't make sense. From a technical view, doesn't make any sense. From the patient comfort perspective, doesn't make any sense. If with the same number you can do fixed, I think we should do fixed. And the argument of the money, but the fixed one is more expensive. Well, it's not, because nowadays with 3D printing, I mean, come on, you can print one it costs you $10 of resin, not even $10, $5 of resin, Right. So it's not a money thing. The locator abutments are also expensive. It's equivalent to a MUA. So there is no reason to do, in my perspective, of overdentures in the upper one. We all only do 2 in the lower because it's a very cheap alternative that helps many old people that are in necessity. But if they can do an all-on-4, the better for them.
Yeah, I have almost completely eliminated upper overdentures from my practice. I've done a handful of them, and mostly it's for... lip support, or maybe the patient just wants something removable for whatever reason that may be, but very rare. And I also noticed that, just in general, maxillae that I would consider to be good candidates for a very good upper overdenture are very few and far between. I don't like planning those and actually trying to get really good parallelism of 4 implants in a maxilla. It's very rare that I look at that and I'm like, that makes sense. Most of the time it does not.
If you ask a patient, look, I can give you a little bit of lip support with this solution, but you have to take it out every time you eat. Or I can give you fixed teeth, you can eat everything for the rest of your life. Sure. Almost like it was natural teeth.
Sure.
Guess what they will...
that's a fair point. Yeah, it's very rare that I'm doing the snaps. I
mean, if you tell a 80-year-old woman, 50 kilograms, very small, that she will have a millimeter more on the lip support, this doesn't even make sense.
Yeah, it's not saying
Who
much.
cares
Sure.
about 1 millimeter in this type of scenario?
Sure. Fair. No, fair
So,
point.
yeah.
Yes, and then another thing that was mentioned. So you mentioned moving away from grafted technique, and immediate load graftless technique is something we've been talking about since probably the first episode. But I am curious about some of the long-term results you've seen in that grafted bone. This is something that we saw in my boot camp. I remember we flapped this patient, and I could still see the particulate graft in this posterior graft sinus lift that had been done.
You can take with a curette.
I can still take it out. Yeah, it wasn't bone by any means. It was just stuff. So what? Yeah, is that more or less what you were seeing a lot of, or where do these things fail out, and when does that usually happen in this grafted bone?
Yeah. So the what usually happens is, let's put it this way, so it's easy to understand.
Yeah.
If you have a upper arch 6 implants.
Sure.
And in one of the sides, you have a sinus lift, and one of the implants is on the sinus lift area. And if you want to make a bet, which implant, so one implant has failed. On the 6, one is failed. If you want to make a bet, which one was it, 99% of the times will be on the implant that is on the sinus lift.
Of course.
This is the statistics.
Sure.
And the literature is it's quite clear on this, that implants on grafted sites fail more times than implants on native bone. Not only on the immediate, but they seem to be more prone to peri-implantitis.
Okay.
And the reason for that is I think it's very easy to understand. So the reason that happens is that native bone has self-defense mechanism, and bone substitute is dead.
Yeah.
So even if you mix it, it will always be the defense mechanism will always be weaker. It will always be slower. So that seems to be the reason on why we are losing more implants and peri-implantitis in grafted sides with bone substitutes. And in fact, even when you have the perfect augmentation with bone substitutes, after 5 years, 6 years, 7, 8 years, the shrinkage of the volume of the grafted area tends to reduce in a much higher rate than the shrinkage that happens naturally in, let's say, for example, a posterior mandible edentulous area.
Yeah.
It tends to shrink more. And when it shrinks more, it may leave your implant exposed. And if the implant is exposed, the colonization, the bacterial colonization is higher, and things start to go south. I don't mean to say that we shouldn't use, ever, but I do think that if we have an alternative within native bone, we will get higher success rates by going that route instead of countless grafts, which are also more expensive, and they also increase the morbidity.
Yes, absolutely. Now, would you say the same about an autograft?
Well, I think that, for instance, you are talking about Kouri bone blocks. It's the typical augmentation I do in the posterior area. So for partials is my number one technique for those types of scenarios. If I cannot place a shorty, let's say posterior mandible, the eternal drummer, right? If I cannot get away with a shorty implant because the ridge is too thin, I would do an horizontal augmentation with a bone block. And the failure rate is so small. It's a bit technical, it is, but the failure is... I never experienced a failure yet when using autogenous bone. And the small exposures that you get from time to time are way more forgiving than the exposures that you may get with a titanium reinforced membrane with bone substitutes inside, let's say. Usually you tend to lose almost all the graft if that happens. But when you work with autogenous bone, 70% of the graft will still be there.
Right. So it's not like a catastrophic failure. You can have like a partial
Yeah, usually it's
dieback.
not a catastrophic failure.
Okay.
Yeah.
Very nice. Very nice. And is there any world for, uh, let's say in the upper, like a sinus lift with immediate loading? Is that even a thing? Is it even possible? Is it a bad idea?
Oh yeah.
Yeah.
Yeah. I showed you one case exactly like that at the master course. You know, that patient
Yeah.
that came from Switzerland. She had a big mucocellus.
Yeah.
So yeah, that's a nice question. For instance, this is I think this is the perfect example one of the situations that we can do a sinus lift. Your sinus pneumatization is so, let's say, second quadrant. The sinus comes so anterior that even if you do a very good and very tilted Allen 4, let's say your prosthetic exit comes on canine first premolar. You know, it's a big cantilever until the first or the second molar. So in that case that I'm talking, I did the Allen 4 and the sinus lift and the implant on the same day. So so in the future the cantilever will be much less. But those are rare situations. If you can place a pterygoid in the same site and just avoid the sinus lift, I would do it.
Yeah, for sure. Yeah. So in essence, it seems like your pterygoid first and then sinus lift is like, okay, well, I don't have that. I don't have anything else. So let's just give it a chance. But that's not what you're banking on.
Yeah. So if I had any option to still work with native bone, I would always prefer it instead of going for the sinus lift. That's a typical situation. Then the Allen 4 will give you cantilever, but you can place a pterygoid. Yeah. Then place a pterygoid, and you have what we call negative cantilever.
Yeah.
When
no, you just have this like extension that goes all the way back there. And I am curious too, because I've gotten this question many times since I started talking about doing pterygoids. I've done a handful since the course and starting to get pretty confident with it, but I still miss every now and then. One question I get is
pterygoids is like video games, man. You remember when we played Super Mario and you die a lot of times in the same enemy?
Yeah.
And at some point you get it right, and then it will go better and better and better.
Yeah. So
when you pass sorry to interrupt.
No.
When you pass the 50% failure on pterygoids, like you start to doing them and maybe you hit 1 in 10, then 2 in 10, 3 in 10. When you pass the 50% mark, it's very easy to go to hit 90% of the times.
Yeah, I think I'm probably like 30 or 40. I still feel very lucky when it happens. I still feel very lucky.
So in 2 or 3 months, you will be like hitting 50% of them. When that happens, I tell you go to 90% super quick.
Great. I'll let you know when it happens. So on that subject. So what I was kind of leading into with the question, and I have 2 questions in the line of pterygoids, but one is, what is kind of the limit of what a pterygoid can help you do? So obviously it's giving you the sort of negative cantilever in an upper prosthesis. And let's say my anterior implants are way up at the vomer or the nose or something like that. Can that be a serviceable prosthesis? Is a question I get a lot.
Yeah, it may work as a work prosthesis or a prosthesis in function if, for instance, you have a lower overdenture.
Okay, don't stress it. Okay.
So yeah. And if the patient is old, is not doesn't have bruxism, it's not recommended. All the studies, literally all of the studies that compare the Allen 4 type of strategy with the Allen 3 show that the bending happens much more when you have a tripod instead of a square.
Yeah.
And we see this in normal life, a 3 cycle, for the kids, they tend to flip that quite easily. But they don't flip a car.
Yeah.
It's the same principle. Dentistry it's so easy to understand and so easy to explain, and we tend to complicate it a lot. So that's the answer. Although I must tell you that I have a good friend in Italy, Dr. David Manni, cheers for him, which did the first case I saw, which was an Allen 3 with 2 pterygoids and 1 in the vomer only. There was no bone for anything else except a subperiosteal implant. And that case was not even a candidate for zygos because
Man.
That's another thing that young doctors tend to get the wrong idea. The idea that if everything fails, you always have the zygos.
Not
Well,
true.
you don't.
Not true.
In many times, the zygos are also so thin that you cannot place an implant there, and you'll break the zygo, or maybe you don't break, but you are placing it too medial, and you are inside the fossa, and you don't even realize it. So, just wanted to stress, because it's important that the audience understands that even if the zygos are there, well, they may not be that useful in some patients. Fortunately, the minority of them.
Right. Yeah. So this is actually, I really want to go to zygos, but let me mention my second sort of nebulous follow-up question about pterygoids. So, what are some of the biggest things that people get wrong with regards to surgical technique with placing pterygoids that you see time and time again? After teaching proper technique and sort of, because I've covered some of like the fundamental principles of how to place a pterygoid, but what do you see people screwing up the most? And it's kind of like something that they just maybe isn't intuitive. They need to change.
I think that the answer is a bit wider, and I will tell you where I want to go with it. Dentistry is mostly a technical professional. We tend to look at us as doctors and stuff, but in reality, this is a very technical thing.
Yeah.
It's like an electricist, or a electromechanical engineer. This dentistry is a profession that uses small tools to work with small objects.
Yeah.
This is what it is. But because it's in a human, we need to know a little bit of medicine. But basically, it's a manual and a technical job.
Yeah.
And we tend to forget this, nowadays. And we tend to look at the job as something that anyone is suitable to do as long as they study. Well, that may not be very accurate, because if you are not good or you are not interested in manual labor, in building things with your hands, creating stuff, if you are not interested in screws, in drills and bricolage, for instance, it will be very difficult to get good in dentistry. And let me make the bridge to your question.
Yeah, sure.
So when we work in pterygoids, you don't see your end point, you only see the entry point. So it's everything a matter of hand haptics, which was a term. Haptics, it was developed by Apple, and I used that term in an article. I think it was the first time in dentistry that term was
That's a great word.
Published within dentistry.
Yeah.
But the thing is, we have to feel it. The hand sensitivity is what will tell you if you are on the right spot or not. And we should start by training that, for instance, in the nose anchorage, by cortical anchorage in the nose. And if we cannot feel it, like 99% of the times when you are in a standard Allen for doing a bicortical anchorage in the nose, then we are not ready yet to go for the pterygoids. Because it's completely blind. You are only trusting your hand sensitivity and the sound sensitivity to make sure that you are there. And we stress this a lot in the course, the sound sensitivity. At the first times, I even ask you to stop the suction, to be quiet in the room, so you hear the difference on the pitch of the drills. Because it's different when you hit the hard bone. So
for sure.
Once you get your landmarks right, the 3 landmarks we talk in the course, then when you drill, is all a matter of sensitivity.
So you mentioned something that's got me going down even more of a tangent on pterygoids. So this was actually a conversation that came up in our Full Arch Club group, and we don't have to use any names, of course, but there's also a very popular movement of people that don't do drilling for the pterygoids, or maybe they do, but it's mostly osteotome driven. It's a totally different concept. Can you kind of elaborate on your technique for placing pterygoids, the haptics involved in that, versus maybe using osteotome approaches?
So, as I told you, I never used osteotome for pterygoids. So I cannot really, have a feedback on how easy or how difficult, that perception may be. But I do know how osteotome feels in the sinus. To break the bottom of the sinus, to do a crestal lift. And I feel, what I can tell you for sure is that, at least in my opinion, is way easier to feel the difference when you reach the cortical with a drill compared to an osteotome.
Yeah.
I feel it much easier because your drilling movement that we talk a lot of times, the in and out and slowly progressing, which doesn't necessarily mean slowly drilling, I mean high speed drilling, but slow progression with the drill. The in and out will always give you that feedback, and when you hit it, you really know you are there. It's like hitting concrete. And my perception with the osteotomes is that feeling is not that easy to spot. But again, I never used it on pterygoids, so maybe you can give me your perspective on that if you have tried both.
I have not. Yeah.
Oh.
No, I'm still trying to master the drill technique before I go trying something else. So we'll see.
All right.
Yeah. I'm trying to just draw from different, experts and how people like to do things, and people can be very dogmatic sometimes. So I think it's interesting just to kind of hear different perspectives, of course. But another, gorilla in the room that I wanted to bring up, and we talked about it briefly, but I would say that probably one of the most sexy things in full arch right now are zygos. They're zygomatics. Everyone wants to go down and learn how to do zygos. They want to expand their practice. And a lot of times when people start getting really comfortable with doing all four in some more complex cases, they say, well, next I have to start doing zygos now. I have to be the zygo guy in my market. Can you talk about some of the things that you've seen as this has become more popular that you think are maybe not the best way of thinking about what the next level is?
Well, the problem with zygos is not the zygo itself. It's not the techniques themselves. It's not even the operator. Most of the times, the problem with zygos is an anatomy problem. And the fact that the anchor point is so far away from the loading point creates a movement that often is not a micro movement, is a macro movement. And when you add together the macro movement of the implant with a slot that very often you have to create on the sinus, because again, it's a problem of anatomy. You have the sinus in the middle. Of course, it depends if it's Zygo 1, Zygo 2. It depends the variation of the individual case, but very often you need to create some slot or some opening on the sinus. And anytime you open the sinus, what you are doing actually is you are allowing the bacteria that can enter the sulcus to migrate apically and start to colonize the sinus. That you get the sinusitis. So when we think about all of this together with the destruction that you need to do on the zygo area to place the implants, and there are no zygos that are less than 3.9 millimeters of diameter, you think that, well, these actually may work for short, medium. You have some articles with long term, but what if this fails? What if you have to redo this case? And my thing with that is, I did a lot of zygos when I didn't have an alternative, but the moment I had an alternative that was less destructive, I had to make a decision. At some point in life, sometimes you need to stand up for something, and instead of saying yes to everything. And at some point, I said, well, I have this alternative, which are the custom implants, so I will do this until I see evidence that will force me to go back. And I haven't seen that evidence yet. I know this is also a new technology. Well, not totally new in the sense that was not created now. The first ones from Dahl in the 40s, from Goldberg, from Lenny Linko. This dates a long time ago. We talk about this at the course, but these new technologies is quite different from what it was in the past. And the fact that the implant doesn't move is one of the things that make it last way longer, because the old ones, after 10 years, the mobility
Yeah.
was usually the reason why they start to expose, they start to destroy bone. When it destroys bone, the mobility increases even more. So after 10 years, the follow-ups had about a 50 to 60% success rate, which is not enough. And so they were mostly discontinued. And then in 88, Brandmark did the first Zygo. In 98, they were available to the public. And they have been a wonderful solution until now. But again, I think it's a destructive way now that we have an alternative.
Yeah.
And about your question on this new tendency to try to learn Zygos as fast as possible, I think that is highly motivated by ego and by the brands that want to push doctors to buy Zygomatic implants, because they cost 3 or 4 times more than a standard implant. And because not all the brands actually sell Zygos, they want to bring the doctors to their club and somehow make them in that sphere of treatment, and that sphere of treatment contemplates the Zygos. And so there is a big push on the industry also for that. And there is also the natural ego, to do something that seems exciting for someone that has been doing All-on-Fours for 10 years. It's a bit, boring, because he has done this for so many times, and it's exciting to do. I tell you, it certainly is. But what's your purpose in life? Is only to find excitement, or is to solve a problem?
Right.
And I think that's the ultimate question.
Mm-hmm. Yeah, no, absolutely. And I have to admit that Zygos are exciting, even with all the other things that I know and I'm trying to get better at before I get to that point. If I even get to that point, I'm sure if I ever do it, it's going right on my Instagram story. I'm going to post the whole CBCT and be like, oh, just a casual, quad Zygo today. But who knows when that'll be. You've certainly delayed that day with your work, of course. So one thing too that I want to kind of help people get a better sense of is, Full Arch Club, you do a great job at teaching about, transnasal technique, and we can talk a little bit about differences between infranasal, transnasal, things like that. Transsinus, pterygoid, all these sorts of ways of giving patients another stop between traditional All-in-4 and going to Zygos. When I first got out and first started doing cases, I was probably referring, I would say maybe 5 to 10% of patients for upper All-in-4 for Zygos, because that's all I knew. Like if I just didn't see a way I could do a traditional, it was getting referred out for that. More recently, I'd say it goes, I refer out maybe 1 or 2% of the maxillas that I see when I just cannot wrap my head around doing it any other way. In your practice, I know. I would say that number has probably shrunk since the boot camp, because we did some absolutely absurd cases there. But what would you say, like in your practice, what percent of cases can be done with these traditional and, pterygoid and other advanced techniques short of a Zygo? Like what's the sort of percentage of patients that can be taken care of with that?
If we are including the new custom Subperiosteal implants, we are talking about solving, not only solving 100%, but also solving quad Zygo failures.
Yeah,
that's the thing,
Right.
Is that with a custom implant, you have endless options. You can replace a full mandible with a custom-made mandible for a patient. You can replace, for instance, nowadays our colleagues in India, they are having a lot of cases after COVID of mucormycosis, which is also called the black fungus.
Mm-hmm.
And the black fungus is so invasive and so destructive that these guys have a total maxillectomy.
It's terrible.
And these doctors in India, our colleagues, have a lot of friends that are sharing me all these dramatic cases. They are the ones with the biggest experience in the world solving maxillectomy cases. and you guess what they are using to solve those cases with immediate loading?
It's customized.
Custom
Yeah,
implants.
of course.
Custom implants. So, so yeah, it's 100% solution within the office, and actually many times even with local anesthesia. To be honest,
I've seen it.
we are using, we are only using general for maybe the superiosteal cases when I see that the patient is a bit too anxious.
Yeah.
But if even if the patient is an okay patient, we can manage it with diazepam and with local.
Yeah, I mean that was an amazing thing at the boot camp too, because I think most of our patients received, maybe it was 10 milligrams diazepam, and I think we did the custom case and it was like, oh well, this one got 15.
Yep.
Which I mean
or 20. Or 20.
Okay.
I'm not sure right now. Maybe it was 20.
Maybe 20, which is still, I mean, that I think there are people in America right now. There's probably 20% of people on the road in Atlanta that are on 20 milligrams of diazepam, no problem. But having said that, so let me branch off my question just a little bit. So let's throw out custom implants for just a moment, just because of the lack of availability. Like in the U.S., there's just not doctors that are able to do it, and there's FDA approval still waiting. So without the customized implants, just with traditional plus teres plus transsinus, transnasal, etc., where does that percentage lie for maxilla?
It's less than 1%.
Okay.
I can tell you. I can tell you it's easy for me to make the calculations. All I do is full arch surgery, and I also know how many custom implants I buy per year. So when I compare the number of cases I treat with the number of subs that I have to buy, it's less than 1%.
Wow.
And I think these numbers are a bit skewed, because I usually don't get referred the easy cases.
Yeah.
So
true.
most of the cases that I get are they failed already, or they were a bit too atrophic or something. So usually I don't have that pleasure that I had a few years ago of having those white crests with a lot of bone.
Never see it.
Sometimes, when I get one nowadays, I sometimes I even feel happy. Like, okay, that's a no-brainer today.
Yeah. Maybe you thin the ridge just a little bit to keep it exciting, so you don't fall asleep during the procedure. Maybe.
No, I wouldn't say fall asleep, but when your life is every day under a bit of tension, sometimes it's nice to get an easy case from time to time.
Of course.
And I'm sure you feel the same, man. You are doing a great job, and I see your cases, and I see what you did in the boot camp. So I think that very soon, if not already, you are understanding perfectly what I'm saying.
Oh yeah,
sometimes
I'm tracking. Yeah, a
large crest with the normal bone feels
it's cheating.
Great at the moment. It's almost like cheating.
Yeah. So since we have broached the topic of custom implants, this is something I haven't talked about a whole lot. I think I've talked about it in terms of its difference between the classic subperiosteals and how we're doing now, which really. It's a totally different world. It's a totally different methodology and how it works. So, the gist of it for our listeners that aren't as familiar, the way the subperiosteals were done before is it was a 2-stage surgery. We'd have to go in, do a bone level impression, cast this big frame, go back in, hope that it adapts very well. And it wasn't really integrated necessarily. You didn't have self-integrating screws and zygotes to retain it. And now with these custom implants, we're using modern technology. We're using milling, and we're making these very beautiful and complex meshworks that actually integrate with the bone and enable us to do virtually any case, just as you were just talking about. Where does that stand? In terms of its coming to America, being more available around the world, because right now it's very limited.
Yeah, so the last estimative that I know is late this year. So
for FDA approval.
Yeah, for FDA approval.
Okay.
So maybe in the fourth trimester of 2023, you'll have this thing approved. So your referral out rate will also go to 0.
Yeah, that's right. So so if someone is listening to this and they want to be the person that can solve virtually any case. Maybe they're already
Mm-hmm.
doing some zygos, and they
Mm-hmm.
want to incorporate custom implants. What's the best way to go about learning it? Because it is, I mean, it's a brilliant prosthesis, of course, but so much skill and know-how has to go into being able to make sure it adapts well, to
Mm-hmm.
know what's really necessary for the prosthesis to be passive. How should someone go about learning the skill itself and being prepared for whenever that comes out?
Yeah, so I am a bit suspicious, as we are. I think we are the first. Pretty sure we are the first company teaching this
Yeah, right.
to international doctors, and also because we started very soon. That's one of the benefits of being an early adopter of
Yeah,
something that you believe is you get this all these years
yeah,
of accumulated experience. And I did my first one in 2017.
yeah.
So you see, 6 years ago, and yeah, you need training on this, and you need training that not only teach you this, but also teach you the principles, general
Mm-hmm.
principles of the old school ones,
Yeah,
uh, because it's such an amazing resource that will literally solve any case, and the new ones, as you were saying, uh, although they may look like the same, if you take an X-ray or something. Era o carregador do computador. Sorry.
no, you're fine.
So although they may look like the same, all the principles are different. So they are now screwed. They are not just laid down into the bone. Everything is done in one day, not 2 days.
Right.
Before it was one surgery for impression and another surgery for placement. Uh, the kind of bone preparations that didn't exist back then exists now to reduce the chance of bone exposure. The design of the implant is based on Champy principles for mandible fractures and the Lefort-1 principles for orthognatics in the upper jaw. So everything is literally so much improved that it doesn't even feel right to call them subperiosteal.
Yeah,
Actually, Rui, the CEO of the company, hates that people refer to this as a sub because it's so different that
yeah.
he prefers to call it patient-specific implant.
Yeah, and I think that
So,
that's
yeah.
that's certainly appropriate. Um,
Mhm.
and actually,
So yeah,
sorry, I actually think that for me, we're talking about going from for uppers, we're talking about going from 99% of patients to 100%, right? But I think that where we stand to give so many more people an opportunity is for lowers, right? Because those are
yeah.
extremely difficult in patients that have, the hourglass mandible or just really weird, super thin biotypes.
Mhm.
For those whom have lost so much bone and, retroforaminally that even core plates and all this grafting is maybe not really going to get it there. You may have a different opinion there. I think that that's a massive opportunity. And they also seem, in my
Mhm.
conversations with you and Pedro, that they're a little bit more technically simple than an upper as well. And I think that's going to open up a
Mhm.
huge swell for people that have been denied lower all-in-fours. I see it all the time,
Yeah,
and
yeah, yeah,
I deny them here and there.
yeah.
I think that's huge.
Certainly. Yeah, the examples you just said are exactly the indications of the lower subs. The hourglass
Yeah.
mandibles that you basically have no option. Very very small ones, very thin ones,
Mm-hmm.
and they are actually printing, for instance, full mandibles for people
Yeah.
that I showed you a case. This patient that had a tumor, then she had a
Mm-hmm.
fibula,
Yeah.
then she lost the fibula,
Yep.
then they did a custom plate. She lost the plate, and now she has a fully
It's wild.
fully printed titanium printed jaw, and she was eating solids 15 days after the surgery. Can you imagine?
I can't.
So
Yeah.
yeah, the future of 3D printing is quite impressive, and what we can do in our field, it's quite amazing. And yet, and the fitting is also better in the lower jaw for a simple reason. The bone segmentation,
Mm-hmm.
turning a CT scan into a surface is way easier to do on the lower than it is on the upper, because the cortical of the lower is much harder. So
obvious,
the fitting on the lower, usually it's even better than it is on the upper. So yeah, it's usually an easier and faster surgery.
Yeah. I wonder if we'll keep this show going on long enough to where I'm talking about how I send a CBCT off to ChatGPT and it does AI bone segmentation, and I get a titanium jaw printed off that we'll be doing cases with.
Oh man,
that would be pretty incredible. It's a brave new world for sure.
we spoke about that in the group.
I know.
Right? I think in the next 2 years you upload a CT scan.
Yeah.
And the AI will do segmentation, the guides if you want to do guided surgery, print the implant, and you just hear a beep when the implant is ready, and you pick it up and you place it. And in 5 years, the robot arm will place it for you.
No, don't.
We will be all out of job. If this is being recorded and it's going to be live, right, on Spotify.
Of course.
If Spotify still exists in 5 years,
yeah,
we will review this interview. We will be all out of job because AI will replace us.
Well, by that time, I'm just going to have an AI recording all these episodes, so I don't have to take time out of my day. I think it's got enough data from all my recordings that there's a digital avatar.
Digital you.
Yeah, exactly. It's probably more likable than me. Yeah.
Like the series Black Mirror.
Exactly. Precisely. Yeah, and I just live my own life, and I just have a consistently rolling podcast. But Bernardo, yes. So we're over the hour here, and I know it's probably 11 o'clock your time now. Hey, how's it going? Yeah, just a moment. Sorry, I am at the office. And I just want to say thank you, so much for coming on and sparing your time and sharing so much knowledge. I know that, you certainly have enough knowledge to where this podcast could probably be a weekly series for about a year, and people would still have more questions. I'm just so grateful for all the things that you're doing. Where can people reach out to you if they're interested in signing up for the master course, the boot camp, or want to stay current on all things Full Arch Club?
So thanks for the invitation again, and it was such a pleasure to have been with you twice in Portugal and in Brazil on the live surgery bootcamp. And for the people interested in learning these graftless freehand techniques, just go to fullarchclub.com, and there we have our courses, and you will learn about the standard Alon 4, Alon X, Palatal Approach, Sinus, Transnasal, Pterygoids, and custom Subperiosteal implants. And you probably get to know, if you go for the bootcamp, you will get to visit the most beautiful city in the world, which is Rio de Janeiro.
Yes.
And you get to do paragliding, like Tyler did, and many others.
Yes.
And when we jump from one of the highest mountains in the city of Rio, which is a quite view as well.
Yeah, no, that was definitely that was certainly my favorite trip that I've done for a course. You picked a pretty good destination for it, and the whole Dr. Fabrizio Goncalves and the whole it was a SIVO situation.
Yeah.
The clinic down there was absolutely incredible, and what what we were able to do for those people down there is an experience I will never forget, and it certainly grew me as a surgeon and a doctor. And in your closing there, it reminded me, and this is almost criminal, that we went it looks like an hour and 9 minutes without talking about palatal approach.
How is this possible?
I'm talking to the guy that trademarked the term, and we never talked about palatal approach. Incredible. Well, it seems that we may have left some topics yet to be discussed, potentially in a future episode, which I think I would be more than happy to have you back on, and if you'd be so gracious to do so, that'd be fantastic.
Sure, man. Whenever you want.
Okay, awesome. Thank you so much, Bernardo, and I'm sure we'll be hearing from you again very soon, and I know my audience is really going to love this episode, so thanks again.
Thank you, and I wish you the best also on this new project, this new podcast, which I heard the last 4 episodes, and
fantastic.
I think you guys are doing great.
Thank you.
I think the topics that you are bringing are super important, not only for beginners, but also for anyone in the dentistry aspect. And I wish you the best. And you are one of the guys that I'm sure will do great in any field he puts his mind into. So Good luck, man.
I appreciate it, Bernardo. Thanks so much. Okay, Bernardo. So there's a couple of other topics here that I wanted to make sure that we covered before we called it here. So we've gone on long enough without talking about palatal approach. And so this is something that's gotten extremely, well, maybe I shouldn't say extremely, but it's gotten very popular very recently. I first heard about it probably 2 years ago. And it was just something that a friend of mine had seen on YouTube and was talking about. And I saw it, and it looked like absolute black magic. And I said, "There's no way that works, but I'll probably try it anyway because at least someone's posting videos about it." And I tried it. And I think I talked about my first experience with that on my last episode with Soren. And there is so much more than meets the eye when you do a palatal approach. And so I was hoping you could kind of give us a little bit of background as to how you came upon the technique, sort of the history of it, the long-term studies, because I think a lot of people still, they'll see it and they'll be a little bit skeptical. And two, all the time I'm talking to patients about why they do actually have bone for it, because it is kind of a trippy concept for people.
Yeah, so interesting that you bring it up. Many people asked me about these things, and initially on the master course, in the first one, we didn't even place the term palatal approach because in my mind it was within the L14. This was part of the L14 technique, and we have just been teaching this since forever, but not as a specific technique. But then the interest that you spoke was so much that I decided, well, I have to make a separate set of slides with a separate set of rules because it actually is a different technique than the L14. And you guys covered it pretty well in your last episode. And so my idea since the beginning was this. If I can place a zygo completely exposed on the buccal, which has the worst soft tissue that we have in the mouth, which is the buccal maxilla.
Yeah.
Usually the zygo gets without any keratinized tissue, gets exposed and all of that. So if we can do it, why shouldn't we do an inverted zygo on the palatal side? With the same principles.
Yeah.
I will create the slot on the other side, the same way we create on the buccal for the zygo. I will have a strong apical anchorage, the same way we have on the zygo, which is the anchorage on the zygomatic bone. But my implant will be covered with the best soft tissue in the mouth, which is the very thick connective and keratinized tissue of the roof of the mouth that will seal and will protect my implant. So we have this thing had to have a name, so it's because it's placed on the palatal side. So it's not a buccal approach; it's a palatal approach.
Fair.
And then we had to find a way to explain this, because it has a lot of nuances. The drilling is different. The approach to the site is different. The slot creation it has slight variations from the slot with the zygo. We are not using diamond burrs for this, and we are also not grafting the threads, which is something that people always ask me: Why don't you graft? Why don't you graft? Why don't you graft? I mean, if we understand the principles of grafting, and if we understand the principles of hemidesmosomal sealing and soft tissue sealing around the implants, around the abutments, if we understand the concepts of Alberto Micelli about the soft tissue and how important it is to obtain the sealing to keep bacteria, food, and foreign bodies away from the treated surface of the implant, it is something that we don't even consider to graft on the inside.
Yeah.
Because if you graft, you create a pocket. If you create a pocket, you will lose your implant very fast, probably for no integration. And even if it integrates, you will probably lose it later for peri-implantitis, as it can be such a big area of the implant that gets exposed and gets to stay with no sealing during the healing of the graft. And that is something we need to avoid. We want soft tissue sealing from day zero with the suture. It starts with the suture.
Yeah,
you can immediately load it every single time. Actually, you have to, because if you don't, you put a removable denture.
It's just sitting on top of it.
sitting on top of the implant, and you get the micro movements, which will turn one day into macro movements, and then it goes to the trash.
That's actually a nuance that I don't think that we mentioned in the episode, is that if you don't load it, if you just give them your conversion prosthesis or a denture, it's not going to do so well. So as a delayed approach, it's probably not going to be quite so successful.
Yep.
And I think that, what you're talking about in terms of bacterial invasion onto that, surface treatment, that's something that really clicked with me a couple of years ago when I was reading Zero Boneless Concepts by Linkovich's, is
Thomas Linkovich's, yeah.
of course. And I'd always just considered, okay, well, screw has to go in bone, and there has to be a lot of bone around it because that's going to give it blood supply, and that's going to keep the implant healthy. And, we're not letting things infiltrate into there. But what you learn, and in full arch as well, is the importance of what you mentioned, the connective tissue and the keratinized tissue, that sort of bedded down tissue that is really what creates that seal away from bacteria ever being able to infiltrate, cause peri-implantitis. And I think switching from that hard tissue to soft tissue concept is extremely important, and couldn't be more poignantly, that point couldn't be better made without, considering palatal approach, because it's that palatal tissue that really makes it possible. So
exactly.
Yeah.
Like you said, Tyler, if we still believe that the implant has to be fully surrounded by bone, then we need to stop doing zygos.
Yeah, right. Yeah,
right.
Yeah. So little of that is actually anchored.
So if one accepts a zygo as a treatment, then by logic it has to accept the palatal approach.
The reverse zygo.
It's the same principle. It's the reverse zygo.
I wish people would stop calling it transpalatal, and just if they're not going to say palatal approach, they should just say reverse zygo. I like that.
I don't know why is this transpalatal. I see a lot of trans words lately.
It's popular
now in dentistry. Transpalatal. Guys,
it's a popular
leave the
phrase.
Trans people alone. Come on.
That's great. And another thing that I wanted to talk about too, and especially since we talk about the word trans, is, and don't worry, I'm not going way off the rails here, but your transnasal technique is very different from the transnasal technique that many will see in different places. Can you talk about some of the nuances there and why you do it a little bit differently than what some people may have seen?
Yeah. So the trans, I think first of all, the semantics are important when we define a word, when we define the technique. So when we say trans something, a transatlantic flight, for instance, what is a transatlantic flight? It's a flight that starts on Earth in one side, crosses the Atlantic, and then lands on Earth again. And it goes through the Atlantic. The same with a transsinus implant. Mm-hmm. The implant starts on bone, goes through the sinus, and then lands on bone again. So in our transnasal approach, we start at the crest, in the what is left of the crest below the nose. We go slightly inside the nose, but we go immediately to the side, and our anchorage point is on the canine pillar. We are not placing it that vertical as on the other technique that was published, I believe it was 1 or 2 years ago in a Brazilian journal. Mm-hmm. And so this is the main difference is the level of how much of the implant is inside the nose and the final anchorage point. Yeah. The Brazilian technique that we were just talking about, the final anchorage point is in the turbinate. Mm-hmm. Is a very small layer of bone that lies there that some guys call it the Z spot. Well, if you print a skull, or if you open a CT scan and you actually measure that lamina is 1 or less in thickness. It's such a small point of anchorage that we really prefer to go, as I told you, we go about 30 to 45 degrees inside the nose, but we go immediately back to the bone again. Yeah. So it's almost like the variation of the Alon 4, the M4 variation, you know, but the ones in the middle enter the nose at the 30 to 45 and immediately go back into the bone again. So the hair space is not that much invaded
Mm-hmm.
compared to the other one. And what we have from reports from patients with the other one, at least I have 2 reports of patients with that technique, and they were people. They did endurance activities. One was a runner, and the other one was a cyclist. And what they say is that the breathing capacity, the breathing volume through the nose, was a little diminished with that approach.
That's
and
tough.
we notice that because we tilt the implant so much more into the sides to engage the lateral wall, that it's almost irrelevant in terms of airspace penetration. Let's put it this way.
Yeah. No, I mean,
So therefore, sorry, the difference in the name. So we call it a true transnasal because it goes really through the nose and back to the bone again. The other one, it's more of an intranasal approach because it never leaves the nose.
Right.
It goes inside, but it stays inside because the turbinate is within the nose cavity.
Sure.
It's not outside the nose cavity. So in terms of semantics, I think it doesn't make much sense to call it, but it's just this. It's just a matter of semantics, nothing against the technique or nothing particular with anyone. It's just 2 variations of something that seems pretty similar, but in reality, it's not.
Yeah, no, I think it is important because I am hearing a lot more people talking about transnasal, and those are 2, pretty different approaches that can have some different outcomes for people. And if you look at the implants that are necessary to do either one, that's also very different. Because I've never done the the intranasal technique on a person, but I've done it on models.
Oh, you need a very long implant,
Oh, yeah.
like 22 millimeters. If you 22 and a half, 25, sometimes 20 if the nasal bone is very resorbed. But yeah, they are 2 different approaches with 2 different landing spots, and different types of invasiveness also.
Yeah, and to think about your access and your visibility of the turbinate versus just accessing the lateral wall. I mean, it's a very different skill set, and you also have proximity to the nasolacrimal duct and all these other sorts of complications that you can have. Whereas if you're I think full arch surgeons get pretty comfortable dealing with the nasal rim, the piriform rim, getting up to the nose and things. It's a much easier bridge to cross, I think, whenever you're lacking that anterior crested bone. So lastly, and I think this is a really important question. So obviously you've taught hundreds of people, if not thousands, throughout your career, and certainly within the context of Full Arch Club, and people have learned a whole lot about you and from you, and that's changed the way that people do dentistry and the way that patients receive dentistry, and there's a lot of value there. But I'm very curious from all the people that you've interacted with from all over the world, what are some of the most important things that you've learned from your students?
I guess the main thing I learned from students that have come with to learn with us is that almost everyone, Tyler, have the same fears and the same doubts. It's not Tyler, it's not Elisa, it's not Katerina, it's everyone has the same fears, the same doubts, and the same questions, and the same goals. And what I noticed since I was a student, and what I still notice today, especially in very academic programs, is that most of the education will not clarify your doubts, your questions, and will not remove your fears. Sometimes it will make them worse. They will create them. And quick example, I remember my first class of biocell, cellular biology.
Yeah, sure.
We were talking about the membranes of the cytosines. I didn't even know by that time what was a cytosine, And this happens in dentistry as well. You narrow down the topic to such a small point that the student cannot even see the bigger picture. And it's impossible to teach people this way. You need to go from macro to micro, not from micro to macro. And I think that at the Full Arch Club, we really think about how we teach, not only what we teach,
Yeah.
and to give you a good perspective and to give you also a colleague's approach on that, not a professor-student approach on that. To make it simple, easier to understand, and to try to anticipate the mistakes that you may do, and trying to teach you ways to avoid those mistakes. Because again, learning with the mistakes of others is the ultimate superpower.
I think that's a great answer, and I totally agree too. Because I in the master course that I was in, I saw people kind of getting in their own way in trying to learn a different approach to cases, because there was so much focus on minutia, things that were not unimportant, but in appreciating the larger picture, I think people tend to gravitate towards that level of detail and sweating the small stuff, so to speak, without really grasping the full message of vastly widening the cases that you could be taking on and how you should approach them and the differences in mentality.
Yeah, like we spoke before. For instance, I was telling you that dentistry is mostly a technical job, and it is, and it's mostly very easy to understand if we get the macro picture right. For instance, if you go to to endodontic congress, you will spend hours and hours talking about the files and the material and how the fatigue resistance and all that stuff, and if you ask a young colleague that just came out from the university, why do you have an apical lesion in the necrotic tooth, he cannot answer you. Really, this simple question. Okay, you have a dead tooth. Why you have a granuloma on the tip of the root? He cannot answer you this in one sentence. Right? And it's very simple. You get full of bacteria inside. The bacteria has to go somewhere. They go out from the only open hole they have, which is the foramen on the tip of the root. So you see, and this is the type of approach that we try to have on the Full Arch Club. It's to make things so easy that a children could understand.
And
then we go in more detail, of course, but the macro picture needs to be clear, and this is perhaps what I learned more from others, is that sometimes the macro was not there yet, and we all, as a community, we need to do a better job at being more approachable and making things more approachable for the people, instead of making them look that complex when they are not in reality.
And I think the example you pose is great, because if you can explain what you just said to a patient and they'll understand in 5 seconds, but if you're asking someone that just has been reading endodontic textbooks for a couple of semesters, they're going to have a much harder time answering that question in a way that they think will satisfy you. But you're right, and I think that Full Arch too. This is a mindset that shift that I have to work with. So when I talk to newer dentists or fans of the show that reach out to me that want to learn more about doing these kinds of cases, I think the biggest mental shift that has to happen is that micro to macro shift, because that's what surgery is. You take the 5x loops off, literally and figuratively. You're looking at the entire patient, the entire arch, and you're figuring out how to get an entire arch of teeth on there and spread the implants out, and you're looking at the entire maxilla. You're not looking at a nutrient canal.
That's a great example, Tyler. In one of the boot camps, one of the students was using a 5x loop, and I noticed that first case he did the incision wrong, two buccal. Second case he did the same mistake, and I was looking at him, and it was like, man, take off your loops. Oh, but I'm used to it, man. Take off your loops and do this incision again. Start on the other quadrant and do it again. And I didn't told him that the first quadrant was wrong. I just told him to say, okay, now you start on the second quadrant and do it again. And he did it right.
Wow.
The loops were narrowing his vision so much that he was thinking he was on the right spot and he wasn't. And that's just another example, how sometimes the latest product or the best gadget can sometimes trick you. And loops for Full Arch, I mean, only if they are small,
Yeah.
with a small ampliation, because you need to see the bigger picture
Yeah, totally. I
in
mean,
full arch and in life.
yeah, I don't know how people do it. And, I think that, learning to think like a surgeon and not like a dentist is just so incredibly important. You make a lot of points like that. I remember one of the best quotes that I heard you say during the course is someone was bending their needle, and you said, "Dentists bend their needles. Surgeons, you are a surgeon today." You know what I mean? And there's tons of little things like that, little nuances where, I think if you are very serious about full arch and you want to do that at volume and you really want to do it competently, you just kind of have to change the way you approach dentistry in general, because everything
Hmm.
about it's different. You're not worrying about a lip on a distal margin on number two anymore.
Exactly.
um, it's a forgiving world, but you're taking on much bigger problems sometimes. But I think you're doing an incredible job at really distilling that down and making it a much more approachable discipline. And certainly, I think the world needs it, patients need it, and doctors need kind of a different way of doing things. And I think I really appreciate the niche that you have and elevating people's ability to do full arch dentistry.
Thank you, man.
Of course. Well, I will bid you adieu once again. We, expounded a lot more on some of the things that we missed in our
You
initial conversation.
you want to ask me any advice for future
Oh,
generation?
of course, of course. I keep skipping ahead. You're doing
This
better at this.
this will be edited, right?
Yeah, yeah.
So
No, no, no worries about that. Yeah,
we
yeah, of
can
course.
have this.
Yes, yes,
Okay.
yes. No problem. And my last question, and this is something I like to ask really everybody that comes on is, what is your advice for someone that is first starting out in full arch? What is your best advice for them?
Number one, find a mentor,
Mm.
and finding a mentor that is already doing what you want to do in the future, and try to work with that person, not for that person,
Mm.
and that is a highway for your proficiency. It's almost like cheating, and that mentor can, the 10 years of experience that you will need to get by yourself with a good mentor, you can do it in 6 months if you get the right one. The second one is start to do bricolage in your own house. Start to change the lamps by yourself, start to fix the chairs by yourself,
Mm.
start working with drills and bolts and
Mm.
screws. You need to be comfortable in doing this, because dentistry is mostly a technical job
Yeah.
that any electrical technician guy would do with the same level of precision that we do.
Yeah.
But we have a degree and he has not. But this is a technical professional, and we need to be good with hands with small objects. And perhaps the third one is to don't search for the money in dentistry. You
Mm.
have to search for the result
Mm.
only. Everything will come after. But if you search for the optimal solution for your patients, I know this sounds like a cliche, but it's really not. If you are truly obsessed with the end result, you will get there naturally. You won't have to do nothing. Things will just
Mm.
happen to you if we are truly obsessed and with this. And you are one of the guys that I have had the pleasure to meet, that I feel that you are an obsessed guy with this topic too. So it will be, for instance, it will be impossible for you not to be successful
Mm.
in implant dentistry, Tyler,
Thank you.
because you just are obsessed. So
Yeah.
we learn and we research and we lose time on things that we really care about.
Mm.
It's the only way to do it in this ultra competitive market of dentistry, is to really like it. If not, if you don't like it today, don't waste more years on this.
Mm.
This is the job with the highest number of depression and suicide rate. Change job today.
Yeah.
Send your letter today. If you really don't like this and you just expect to get rich, change the job today before you put a bullet in your head, because
Mm.
it's a very hard job, mentally, physically, and it's wonderful for those who love it, and can be a misery for those who really are kind of in between.
I
And
could not agree. I mean, all of those points are fantastic, but this last one is extremely impactful because, um, I am obsessed with what I do and I love what I do and I still have some shit days. So
Yeah,
I can only
yeah,
imagine, if someone is,
yeah. And that's what saves you in the bad days. Is the
yeah,
passion, is the
100%.
obsession.
Yeah. Yeah.
If you don't have that passion and obsession, it's easy to fall in the bad days and to feel miserable, to consider changing careers or 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 even to think negatively about yourself,
Yeah.
and your competence, and then if you are on the right spot. So yeah.
Yeah, and I think that too, in our profession, something that's very endemic to it is imposter syndrome, right? We have this idea that we're not really cut out to do what we're doing, and we didn't really deserve to get where we are or to be doing the sort of work that we're doing. And it's very easy if you have one of those bad days to be thinking maybe I shouldn't be doing full arch. And then, but if you are obsessed, then you need only look around and look at your bookshelf and see the 3 or 4 textbooks that you have up there, and how you've just been thinking and talking about it with all of your waking hours. And I think you make a great point that if you don't feel that passion, if you don't feel that obsession, then it's really not worth getting into.
No,
And
no,
so,
certainly not.
yeah, I mean, I think that most people that are listening to this can feel pretty assured that if you're listening to a podcast that's just about full arch, you're probably pretty obsessed.
Oh yeah. So
You can't be in it for the money if you're listening to this.
if you like surgery, it's
Yeah.
impossible not to like full arch. It's like the best
Uh,
of both worlds, surgery and implant dentistry. It's like,
you can't beat it. I do love what I do, even on the worst days. I wouldn't trade it for a good day anywhere else. This is what I do. Bernardo, thank you so much for closing with that. I think that's probably some of the best advice for new grads that we've had on here. And just like most of the things you teach, it's very big picture. And I think that, couldn't be a more important sentiment for, all the young dentists and people that are looking to incorporate full arch out there that are seeing that rising tide and need some way to contextualize that. So I really appreciate it.
thank you, man. Thank you. And have a great success on your personal, professional life and also on this podcast, which will be certainly, as you are one of the obsessed guys in the field.
As such, my personal and professional life are virtually the same. But thank you again, Bernardo. I really appreciate
It's
it.
impossible, yeah, it's the work-life balance. They say if you are really obsessed with your job, it doesn't.
No
exist.
such thing. No such thing.
Only exists on Instagram. The perfect work-life balance.
Yeah.
It's only on Instagram. If you ask Jeff Bezos, how is he switching off from work? If you ask Elon Musk, if you ask Bill Gates, if you ask Warren Buffett, there is no such thing.
Yeah.
As switching gears. Now it's
Right.
work. Now it's not. It doesn't exist.
Yeah.
That's the biggest lie I see most repeated on social media.
Yeah, yeah.
It's the work-life balance.
Yeah,
If you are obsessed, that doesn't exist.
Yeah.
You have to deal with that. Grow thicker skin, and learn to deal with that.
Yeah, yeah. Weekends are an illusion. It's just another day of the week. Yeah, I can tell you're an obsessed one as well. But yes, again, thank you so much, Bernardo, and we'll have you.
Thank you, man.
We'll have you on again soon.